So welcome everybody to today's ACLP Virtual Journal Club session. So the ACLP Virtual Journal Club focuses on articles from the ABPN's article-based continuing certification pathway for CL psychiatry. If you are interested in presenting at a future journal club, please let us know, and we can certainly make that happen. For today's journal club session, I am very pleased to introduce Dr. Elizabeth Madva. Dr. Madva is an assistant professor of psychiatry at Massachusetts General Hospital and Harvard Medical School, and she is an associate program director of the MGH and McLean Psychiatry Residency Program. Dr. Madva's clinical and research expertise is in functional and somatic syndromes with a special focus on disorders of gut-brain interaction. Today, Dr. Madva will be discussing a 2017 article entitled Non-Cardiac Chest Pain, a Review for the Consultation-Liaison Psychiatrist. I'm particularly excited because Dr. Madva is one of the co-authors of this, so should have a lot of information about this topic. In terms of logistics, Dr. Madva will speak for about 20 minutes, and then we should have about 8 minutes for discussion. If you do have any questions for Dr. Madva, please put them in the Q&A feature below, and I will try to get through as many as I can at the end of the presentation. With all of that said, Dr. Madva, please take it away.
Great, thank you so much. Thank you everyone for joining and for having me today. So as Chris mentioned, I have a really strong interest in functional and somatic syndromes, and I specialize in what I would call GI psychiatry, specifically the management of disorders of gut-brain interaction, which from here on out I'll refer to as DGBI, also known as functional GI disorders. So I have a clinic that's embedded within gastroenterology at MGH that I started in 2021, where I provide direct clinical care for patients with these syndromes and also supervised trainees. And I also do clinical research with this population. And today we're going to talk about this article that I had an opportunity to work on nearly a decade ago when I was at PGY2. I'll just say quickly, it was interesting to reread it from my current lens as compared to how I was thinking about it at that earlier stage. I do think that there have been some helpful updates since then. So I'll make sure to add those in to our discussion today. So here's what we're going to talk about. What is non-cardiac chest pain? We'll talk about the differential diagnosis. We'll spend a little bit more time thinking about a somatic symptom disorder versus a functional somatic syndrome. And then we'll talk about treatment approaches. So both from the perspective of the article as well as adding in more recent updates. So what is non-cardiac chest pain? Put simply, it's chest pain in patients who do not have heart disease. This term is broad, and so not surprisingly, the differential is broad too. Before we talk about the differential, let's think a little bit about the epidemiology. So chest pain as a presenting complaint is exceedingly common, and because of the association of chest pain with various life-threatening etiologies, in particular myocardial infarction, not surprisingly, it prompts urgent or emergent evaluation 2 to 3 times more frequently than other presenting symptoms, and can be associated with really high levels of anxiety. Non-cardiac chest pain is common. So of chest pain cases, over half presenting to the emergency room and over 80% in primary care will have a negative cardiac workup and non-cardiac chest pain. It's expensive. It's as much or greater than the cost of patients presenting with an acute coronary syndrome. And patients have a diminished quality of life on par with coronary artery disease as well as other chronic medical conditions. And distinguishing different types of chest pain is certainly an area of public health outreach, given the life-threatening etiologies that chest pain can represent and how common it is. It's not uncommon to see ads like this. And as we mentioned a moment ago, it has a really broad differential. So when we think about the sort of quote-unquote medical differential after cardiac causes are excluded, there are gastrointestinal, pulmonary, musculoskeletal causes. In terms of the psychiatric differential, also pretty broad: panic disorder, generalized anxiety disorder, somatic symptom and related disorders, depressive disorders, personality characteristics, substance use disorder. I think the article does a nice job of summarizing these different potential etiologies, so I'm not going to spend a lot of time on them here, but I would highlight that on the psychiatric differential, panic disorder is one of the most common. So about 70% of panic attacks feature chest pain as a symptom, and about 31% of patients with non-cardiac chest pain have panic disorder. There was an interesting meta-analysis. It found that chest pain presenting with the following features has higher rates of panic disorder. So if it's an atypical quality of the chest pain, female sex, younger age, high levels of self-reported anxiety, and absence of known coronary artery disease, all these things among patients presenting with chest pain correlates with higher rates of panic disorder. And then, of course, our functional syndromes. So we want to think about those too. So we think a little bit more about somatic symptom disorder. As a reminder, the diagnostic criteria for this are you have to have one or more somatic symptoms that causes distress or psychosocial impairment, and it has to be associated with at least one of the following in excess. So excessive thoughts, excessive feelings, or excessive behaviors. Importantly, the somatic concerns don't need to be medically unexplained, and you have to have symptoms for at least 6 months. An important question, though, I think, is how can we distinguish between a somatic symptom disorder and, a functional somatic syndrome? Are these the same? Are they different? This distinction isn't talked about too much in the article, but I think it's important for us to think about. So if we look at the diagnostic criteria for different types of functional chest pain, as set forth by the Rome Foundation, as a reminder, this is the organization that provides the diagnostic criteria for the disorders of gut-brain interaction, DGBI, that includes conditions like IBS. Then we see there's actually 3 conditions in which chest pain is the prominent symptom, but with some variation. So functional chest pain, this is a recurring, unexplained retrosternal chest pain that does not feel like heartburn and has a frequency of at least once a week. Then there's something called functional heartburn. This is a retrosternal burning sensation that's refractory to optimal anti-secretory therapy and has a frequency of at least twice a week. And then there's something called reflex hypersensitivity. This is could be heartburn or chest pain or both. And there has to be evidence of the symptoms being triggered by physiologic reflex and something called pH monitoring. And this has to have frequency of at least twice a week. For all 3 of these, there's no evidence of pathologic reflux disease or eosinophilic esophagitis, and there's no major motor dysfunction, though there can be some dysmotility. And for all 3 of these, they have to have criteria fulfilled for 3 months with symptom onset at least 6 months before diagnosis. And from what I can see, functional chest pain as an etiology of non-cardiac chest pain accounts for about 1/3 of patients presenting with non-cardiac chest pain. So in terms of trying to distinguish between somatic symptom disorder and functional somatic syndromes, specifically in this case, these 3 conditions, the main difference is that these diagnoses do not satisfy the criterion that stipulates that patients have to manifest excessive thoughts, feelings, or behaviors associated with the somatic symptoms. That said, having one of these conditions certainly does not exclude the possibility of having a comorbid somatic symptom disorder if all the diagnostic criteria are also met. And the key to establishing whether the patient with one of these conditions also has somatic symptom disorder is determining whether the cognitive, emotional, and behavioral responses to that diagnosed condition are excessive compared with most other patients with that same condition. In addition, we would typically see greater impairment in functioning, so whether it's interpersonal or occupational or physical or all types. We currently see greater impairment of functioning among patients who have both a functional syndrome plus somatic symptom disorder compared with patients who have a functional syndrome alone. So in summary, a patient could be diagnosed with both one of these DGBI and somatic symptom disorder. I've certainly seen that in my clinical practice. So for example, a patient with chronic abdominal pain, the specific diagnosis for that's called centrally mediated abdominal pain syndrome. So a patient with chronic abdominal pain who, despite numerous reassuring examinations, maintains a really high level of worry that the symptoms might represent something more serious like cancer. So next, I think it would be helpful to take another kind of quick detour from the article and think a little bit about how we conceptualize the pathophysiology of the DGBI, including these 3 forms of functional chest pain. So historically, the DGBI were defined as conditions that had no organic basis, but we now diagnose them based on the presence of symptoms, so they're not considered diagnoses of exclusion, and we also conceptualize them as biopsychosocial disorders of gut-brain miscommunication. What does that mean? So we know that there's a robust connection between the brain and the gut. Importantly, we have our central nervous system. So that consists of our brain and our spinal cord, and the gut has its own nervous system called the enteric nervous system. The central nervous system and the enteric nervous system share many features, including a diverse population of neurons and neurotransmitters. Actually, about 90% of the body's serotonin and over half of its dopamine are synthesized in the gut. And we know that there are bidirectional gut-brain interactions that regulate many key physiologic and homeostatic functions, including things like food intake and immune regulation. And basically there are afferent, so gut to brain pathways that transmit information from sensory receptors and visceral GI organs to the brain, where then cognitive, emotional, and behavioral responses to that input are orchestrated. And this input is processed and continuously modulated both at the level of the brain and also through descending modulatory pathways. And importantly, as a result of this, something like a visceral pain perception, for example, does not display a linear relationship with the intensity of the peripheral afferent input. And increasingly, we're understanding more about how dysfunction in something called interoception. This is the process by which the nervous system senses and interprets internal physiologic signals, and this includes both these bottom-up and top-down psychological, neurological, and biochemical processes, is thought to be mechanistically integral to DGBI pathogenesis. If we want to be even more comprehensive, models are increasingly referring to the microbiota gut-brain axis. Yes, there's an esophageal microbiome when we're thinking about functional chest pain specifically. And we can see the impact of stress across this axis at each level. If we zoom in on the gut, we can see some examples of the impact of stress. So for example, on microbiome composition, this affects the microbial synthesis of neurotransmitters like serotonin, as well as the microbial synthesis of things like or metabolism of short-chain fatty acids and bile acids. And these can all act as signaling molecules locally to alter the properties of enteric neurons, leading to changes in motility and secretion. They can also act as signaling molecules more distally. Stress increases gut permeability. It leads to immune activation. It leads to changes in GI motility and smooth muscle contractility through the enteric nervous system. And it also leads to something called visceral hypersensitivity, which is basically where it heightens the experience of painful sensations, as well as increases sensitivity to normal physiologic sensations. So that could include something like distension or, say, physiologic reflux, such that those symptoms can be experienced as painful or distressing. Importantly, we think of these disorders through a biopsychosocial lens. So we conceptualize them as resulting from complex and reciprocal interactions between biological, psychological, and social factors. So there are genetic and environmental factors, things like early life experiences, trauma, exposure to illness, that influence both the brain and the gut. In the brain, we have psychological or psychiatric factors, things like anxiety and depression, symptom hypervigilance, catastrophizing, as well as evidence of differences in functional network connectivity and modulation of interoceptive inputs, which we just mentioned a moment ago. And then within the gut, we can also see things like motility disturbances, altered mucosal and immune function, altered gut microbiota, increased gut permeability. And then the brain and the gut in turn interact bidirectionally via the brain-gut axis, which includes our central nervous system, the gut's enteric nervous system, which is part of the autonomic nervous system, as well as the HPA axis, which, as we all know, is our, the body's principal neuroendocrine stress system. And the idea is that the integrated effects of kind of all of these factors come together to determine the illness experience and the clinical presentation, as well as the clinical outcomes in terms of things like quality of life, daily function, healthcare use, associated costs, and that these outcomes in turn affect the severity of the disorder. So for example, an individual who experiences physiologic reflux who also happens to have, high life stress, maybe a history of trauma, those differences in functional network connectivity, maybe also some altered bacterial flora, that person would have a higher likelihood of developing a functional chest pain syndrome than someone who doesn't have those additional factors. Importantly, based on independent epidemiologic studies, it's about 50-50 whether these conditions present with GI symptoms or some kind of psychological distress first. And also importantly, kind of when we look across the DGBI, across all of the diagnoses that fall into that category, about half of all patients will also meet criteria for a comorbid psychiatric disorder. So basically half of patients might have a psychiatric disorder and the other half might not. And so in summary, the key idea here is that biological, psychological, social factors are all essential to our understanding of DGBI pathophysiology and importantly to the formulation of an effective treatment plan. So let's think about treatment. How do we think about it as CL psychiatrist? So before psychiatry sees the patient, ideally a cardiologist and often also a gastroenterologist, depending on the nature of the symptoms, has completed a careful physical examination, appropriate diagnostic workup. And this is really an essential first step in terms of increasing the patient's receptiveness to being seen by psychiatry. Then as the psychiatrist, we want to make sure to establish an empathic and therapeutic relationship, actively listen to, validate patient concerns, elicit the patient's understanding of their illness. We want to make sure to do our broad psychiatric diagnostic assessment, thinking about all those diagnoses that we listed briefly earlier. And then in terms of the next steps in kind of the treatment pathway, I'm going to focus most on those cases in which it's determined that the patient does have a functional somatic syndrome, whether or not they might also have another psychiatric disorder as well. So education and delivery is incredibly important. It's important to provide the name of the diagnosis. The article suggests terms that may be better accepted and less stigmatizing to patients. In particular, using terms like persistent physical symptoms is preferred to something like medically unexplained symptoms. And as with many functional syndromes, patients can feel stigmatized, they can feel dismissed. It's important to emphasize that the symptoms are real, and it can be helpful to provide education about what we understand about the likely pathophysiology, which we just talked about. And that really can be very validating and can help set the stage and provide the rationale for a multidisciplinary biopsychosocial approach to treatment. It's also important to help set expectations that, similar to other chronic medical health conditions, it will likely take some time and trial and error to see improvement in symptoms. It's unlikely for there to be a quick or singular fix, and it can be helpful to focus on improving function and quality of life more than the focus of sort of complete resolution of symptoms or cure. So then when we're thinking about the actual steps of treatment, pharmacotherapy, this includes symptom-focused medications, things like antispasmodics, acid suppressants. Patients with reflex hypersensitivity in particular tend to respond well to acid suppressants. And these are often referred to, these sort of symptom-focused medications are often referred to as first-line medications within the DGBI literature. We also have gut-brain axis targeting medications, things like antidepressants and other psychotropic medications, which in GI we refer to as pharmacologic neuromodulators, or more commonly just neuromodulators. This term was selected to clarify their indication in this setting, reduce stigma, and improve treatment adherence. And though there was an inconclusive meta-analysis cited in the review paper, there have since been many supportive studies as well as other meta-analyses supporting the use of these neuromodulators, or kind of brain-gut axis medications. Then we have our behavioral health interventions. In the DGBI literature, we refer to these as brain-gut behavior therapies. These are psychotherapies that have been adapted to specifically address sort of the modifiable factors underlying that gut-brain dysregulation, which we just talked about. Then there's also breathing interventions, things called breathing retraining programs, particularly helpful in cases of hyperventilation. It's also something called diaphragmatic breathing. And then we have our complementary therapies, things like acupuncture, other mind-body interventions like biofeedback. Overall, I would say the research for complementary therapies has been a bit mixed, and most meta-analyses tend to suggest that more rigorous studies are still needed. But anecdotally, though, I've had patients really benefit from these approaches, so I think we'll just have to see kind of what the research continues to show. And I thought it'd be interesting to think a little bit about pharmacotherapy from the perspective of the gastroenterologist, and particularly the neurogastroenterology and motility specialists who treat functional chest pain. So as we know that the enteric and central nervous systems share many of the same receptors and neurotransmitters, the basic idea is that psychiatric medications can be used to treat disorders such as the DGBI that involve both the gut and the brain, and that these medications can specifically improve gut symptoms. So as shown in this table, interestingly, these are some of the medications that a neurogastroenterology and motility specialist might consider for functional chest pain. So trazodone, venlafaxine, SSRIs, or TCAs, these are all off-label uses of these medications. I'll say in my experience seeing patients with non-cardiac chest pain, I more often see TCAs, SNRIs, or medications like gabapentin or pregabalin prescribed. Here's another graphic demonstrating how, quote unquote, these neuromodulators might be selected by gastroenterologists. So from my perspective, I'll say, well, so first from the gastroenterology perspective, if anxiety or depression is prominent, they might think about an SSRI. If pain is prominent, TCAs are really considered first line. If a patient has early satiety, nausea, vomiting, or weight loss, we might think about something like mirtazapine. And then if a patient has a lot of pain but can't take a TCA for some reason, we might think about an SNRI. And then there's a variety of augmentation strategies described in the literature, whether it's buspirone, gabapentin, pregabalin, a variety of atypical antipsychotics, and then of course our brain gut behavior therapies or behavioral interventions, which we'll talk about in a moment. Bupropion doesn't tend to be used too often in the GI setting because it can contribute to nausea, though would, perhaps be considered if fatigue and sleepiness are prominent. And I'll just say in, my perspective, when I'm considering recommending a medication for a patient with a DGBI, my primary approach is to evaluate for the presence of a psychiatric disorder and then make a recommendation for a medication that both treats the psychiatric disorder and has a side effect profile that can be harnessed to also treat the GI symptoms. So for example, most SSRIs increase motility, so that could be a good choice for a patient who has anxiety and constipation. That said, I do see patients for whom I do not think they have a comorbid psychiatric disorder. As I mentioned a moment ago, it's about 50-50 across the population. And so in those cases, I try to consider medication recommendations more from the perspective of our neurogastroenterology and motility colleagues. And I have seen patients, even without psychiatric comorbidity or without obvious psychiatric comorbidity, get better with treatment with low-dose TCAs or gabapentin, for example. So let's think a little bit more about the behavioral interventions that can be offered. These are clinician-administered short-term non-pharmacologic interventions that prioritize the remediation of the somatic symptoms over improvement of psychological comorbidity, though the latter is also possible. There are 5 categories of brain-gut behavior therapies or behavioral health interventions that currently have evidence. They're shown here in green, and then their therapeutic targets are shown in blue, with the DGBI symptoms being in the middle, sort of a target for all of them. Importantly, of these therapies, GI-focused CBT and gut-directed hypnotherapy have been the most studied and thus have the greatest evidence. And the majority of studies have examined their use in IBS or functional dyspepsia because these are the most common DGBI. But expert consensus is that they're very likely to be clinically beneficial for other DGBI as well. And it's expected that future research will show this. And as we talk about in the article, there have been studies looking at both CBT and gut-directed hypnotherapy for non-cardiac chest pain specifically. In terms of the effectiveness of these different interventions, a recent meta-analysis examined randomized controlled trials of sort of all of these compared to either a control condition or usual management for IBS in particular. And the number needed to treat for CBT was 4, and the number needed to treat for gut-directed hypnotherapy was 5. Interestingly, the pooled effectiveness for antidepressants for IBS is very similar. It's about 4.5. So pretty good for all of these and about equal to each other. A little more about CBT. So CBT has been very well studied for the DGBI. There have been more than 30 randomized controlled trials supporting its use in multiple forms of delivery, including group-based, internet-delivered, and with minimal therapist contact. This graphic provides an example of something called GI symptom-specific anxiety. We could imagine specifically manifesting as chest pain and how it might be a target of CBT. So let's say someone is out with their friends, they move their body in a funny way, they feel a pang in their chest, they have an enhanced perceptual response to that normal sensation. Ooh, what was that? That leads to the anxiety. Having a pang in my chest is bad. That means something must be wrong, right? And then leads to behaviors out of proportion to symptoms. I think I better leave. Nobody understands me anyway. And so this is just an example of kind of where CBT would try to intervene. So thinking about how to bring all this together in terms of integrated care for non-cardiac chest pain, this figure depicts one approach to care based on a patient's presenting concerns and shows 3 examples. Patients presenting primarily with pain or maybe some other GI symptoms such as nausea, patients presenting primarily with anxiety, depression, or patients presenting primarily with this GI-specific anxiety. For all of these, the foundation of treatment would be the same and would include a combination of symptomatic medical treatment, lifestyle modifications, but then the next steps might differ. So for example, for prominent pain, an earlier step would probably be prescribing a medication, getting it to an optimized dose, and so that they are in a place where they can participate in a behavioral therapy. If anxiety or depression is more prominent, probably an earlier step would be referring them to psychiatry, collaborating with psychiatry for the gastroenterologist to prescribe a medication, and then perhaps later thinking about a behavioral intervention. And then patients, presenting primarily with GI-specific anxiety, likely kind of that referral to a brain-gut behavior therapy or behavioral intervention would happen sooner. Importantly, it can be helpful when the gastroenterologist or the cardiologist presents all the potential aspects of treatment, education, medication, brain-gut behavior therapies right at the beginning of integrated care, so that if and when a patient needs to be referred for one of these behavioral interventions or to psychiatry, it can be understood as just another logical step in their management of their condition. And interestingly, there was a randomized controlled trial that directly compared gastroenterology-only standard care with integrated multidisciplinary care, and they found that integrated multidisciplinary care, in this case, it included a gastroenterologist, dietitian, psychologist, psychiatrist, and biofeedback physiotherapist, that this was superior to gastroenterology-only care in terms of improving symptoms, psychological state, quality of life, and also cost of care. And then in the article, we also talk about the potential benefits of integrated care models or care management approaches. This was based on some similar work that had been done in the UK, in which there's a shared assessment with a cardiologist, a CL psychiatrist, and a biopsychosocial formulation is delivered. Chris and I actually got to pilot an approach like this. This was specifically a nurse care manager intervention for non-cardiac chest pain, in which there was a cardiologist and a nurse care manager who assessed a patient together, convened with a CL psychiatrist, and then delivered a biopsychosocial formulation. And this was followed by weekly supportive phone calls with the nurse care manager for 8 weeks, in which CBT principles were also introduced. We had a lot of difficulty with recruitment, but we did have an opportunity to pilot this in a very, very small number of patients and had promising results. So mean scores for chest pain severity, chest pain frequency, depression, anxiety, and somatization all improved. So in summary, today we talked about what is non-cardiac chest pain. We talked about the differential diagnosis. We talked a lot about somatic symptom disorder versus a functional somatic syndrome and how to think about treatment as a CL psychiatrist. Thanks.
Awesome. Thank you very much. That was great. A lot of information.
Should I stop my share?
Sure. Well, no, you keep it up, I would say, just
Okay.
in case we need to go back to some slides.
Sure.
But I would say one question that I have, and this came up for me recently, is what do you do with patients who have coronary artery disease and who have cardiovascular problems, and yet also seem to potentially also have non-cardiac chest pain on top of it?
Yeah, I think that's a great question. And I know that there's also this area within cardiology, sort of microvascular. So there's also this, patients who may have underlying cardiac disease, but it's harder to find or identify on testing. I think in those cases, it really just, using our CL psychiatry principles, thinking about an appropriate treatment for whatever comorbid psychiatric disorder we think they might have, and hopefully that would benefit the symptoms. And interestingly, I mean, I see that within gastroenterology as well. So patients who maybe don't have what we classically consider as a DGBI, but they have somatic symptom disorder at the same time. Somatic symptom disorder can really be comorbid with any medical condition. It's just when those excessive thoughts, feelings, and behaviors are present.
Well, I guess in terms of you mentioned one of the challenges of the collaborative care type or the care management study for non-cardiac chest pain was difficulty kind of with recruitment. How much resistance, I guess, in your clinical practice do you find patients have to actually engaging in some of these treatments that we're offering?
So I think in my case, it's a little specific. I think that, the sort of pathway to being referred to me, they're seen by general gastroenterology, then they're seen by neurogastroenterology and motility. So there's like a, even more specialized area within gastroenterology, and then they get referred to me. So by the time they see me, I mean, it tends to be patients who have more refractory symptoms and maybe have already tried a lot of things. And so they're kind of very open to thinking about anything that might help them. It's more rare, I would say, that I see someone who's not open to thinking about something that might give them some relief from their symptoms.
Okay, cool. And then we did get a request, if possible, whether we could post these slides somewhere. So maybe we can talk about that offline just so folks can kind of take a look at the references.
Sure. Yeah. Sorry, it was a lot of too much content, I think.
No, that was great. All right, well, I think we're just about at the hour, so maybe we can kind of stop there. So first, thank you so much, Dr. Madva, for presenting all of this information and taking us through non-cardiac chest pain and DGBI at the same time. If anybody is interested in presenting at one of our future journal clubs, again, please let me know, and we can certainly make that happen. And then thank you to everyone who came. Have a nice rest of the day.